We can go ahead and get started, and we will. And I just, again, want to welcome everyone. I can't believe it. This is the fourth of our 5-part series, our quality series. And today, Angie will be taking us through antibiotic stewardship. And I've previewed the presentation, and I'm sure she'll give you this heads up as well. I think we'll be looking for some feedback from those on today. So just get your mind wrapped around that. And the recording has started, so this is being recorded. And once these are uploaded and on our website, Caleb will be sending out links to all of this series. And I'm Kim Mayo. I've been on all of these with you. I'm a program specialist here at the DRCHSD program, which is providing today's webinar. So if we would like it, if you are able to find that chat box, which is at the lower portion of the screen, and there is there's a box that says chat. And if you'll click on that, or there's a link that you can click on that says chat. And if you could let us know your name, your organization, and your role at that organization, that would be super helpful. That just gives us a good feeling of who's here and gives our speakers some feedback as well. All right. If you have any questions or comments throughout today, we encourage you to use that chat box. We always like to hear from you. You can unmute and talk that way. If you're on a phone, I believe it's *6 that if you're using a phone to listen in, that can get you unmuted. And but otherwise, if you'll stay muted, that just really helps to cut down any background noise that's going on there. And all right, so Caleb has advanced our screen. Thank you for that, Caleb. And this is funded. We always remind you that the Delta program is funded by the Delta Regional Authority and the Federal Office of Rural Health Policy. So we're very thankful for those guys. All right, so as you can see, we have one more presentation next week on the May 12th. And that will be focused on the patient-centered medical home. Angie will lead us through the ins and outs of that. So we're excited about that. I can't believe we'll be concluding that. ACHE credits are available for today's webinar. In order to gain those credits, Caleb will be sending out an email with a link to complete for that. All right, so as always, we're going to do some pre-polling questions. Caleb will launch those for us. Thank you so much. So you should see some questions pop up there. And so we would just want to know about your understanding of how to identify antibiotic stewardship activities that are best for your healthcare organization. And then we would also like to know your understanding of how to establish a gap tool for the antibiotic stewardship activities currently underway. So I'll let you all complete that. And I think Angie's not a stranger to us, but if you've been here for any of these, but I'll go ahead and give her her accolades. She is a registered nurse with over 30 years in healthcare. She has a bachelor's degree in nursing, a dual master's degree in both healthcare administration and business administration, and doctorate in business administration. She is certified in both Lean Six Sigma and Black Belt in Six Sigma. She has over 12 years experience in rural health, helping hospitals and clinics improve workflow, enhance quality enhance quality outcomes, whatever, and implement new service lines with their hospitals and clinics. So, Angie, I think you better take it away.
Hey, everybody. Thank you again for joining. A lot of familiar faces or names I'm seeing. So it's nice to see everybody. As you know, this is a collaborative group, and this is we must share. So we're going to use the chat or unlock or unmute your phones periodically or raise your hand. And my friends at the center will let us know when somebody's got their hand up as well. I will tell you right now, this is not, of all of the presentations, this is not my strongest suit. And you are going to see there's only 23 slides, but just about every one of them, I think I have a question on. That we're going to talk about. How are you doing this? What are you doing for this? So that we can learn from each other what's worked and what's not worked. You know, the CDC puts things out there, and unfortunately, they're built for bigger hospitals. So this is where we get to rely on each other and help each other through this. And we've all had pains in this area. We've all had bumps along the way. So it's good to share those. And it's good to share it in a venue that, you know, you don't even have to, you know, have your camera on or be in front of people. So with that, I am shutting my camera off because as all you know, I am very dramatic when I talk. So, and I am going to apologize now because I do have a cold. So hopefully sound is okay. And we're just going to kind of wing it from there. All right. So I'm going to stop my video. Okay. So let's get started. Objectives, what we're going to go through. We're going to go through the CDC framework. This is straight out of CDC. And then I have questions. We're going to look at the gap analysis tool that they have provided for hospitals, and then look at some trends or opportunities of what you guys are doing for outcome measures. You know, because I think this is where sometimes, you know, we don't have any other resources. Who's doing what? And we don't want to use NHSN, you know, when we're reporting, you know, in the patient safety portal, the annual survey. We want to learn from each other and say, okay, what do we need to know? What do we not know? You know, and how can we change and make it better? So we have core elements. This is what the CDC has put out. Now, this came out in 2014. So we had this available. We've all been slowly processing, implementing, and putting things into action. So of these, there's 7 core elements. And I honestly, I have not seen a recent MBQIP report to look at if the newest data is out there and released yet. So if anybody happens to have their most recent MBQIP report, it would be great to hear if you have that newest data to look at. So, but we're going to kind of step through and go through several of these. One of the areas that I do want to note is in 2014, we only had 41% of our hospitals reporting in all 7 elements. And in 2018, that did jump up to 85%. What I anticipate is, you know, through our MBQIP reports that we have, you know, for our cause, I am guessing that number has gone up since then. But then in 2019, released in 2020, CDC added some changes. So we're going to kind of walk through some of those changes and then how are you guys doing this? So in that first section, hospital leadership, they started by breaking down a few new things. They said there's priority areas that you must address, as well as other examples and areas to address. So what does that really do for us? Well, you know, it's just there. You know, we're still having to address all the same things. They've just reframed it a little bit. So under our priority, you know, we're really going to focus on, you know, some of these examples on how you really emphasize the necessity of antibiotic stewardship programs through the leadership platform. You know, looking at how is leadership engaged? What is leadership assisting in providing resources, including the staffing? And that they schedule, you know, regular meetings, appoint a senior team member as the champion, and then reporting ongoing activity and outcomes. So the one thing I really want to emphasize here is, you know, in that priority section is that first one, you know, giving leaders time to really dig deeper into their program. You know, it's, you know, conduct some of those interventions, rounds, and, you know, really look at, okay, is my program working? And then we have other examples. How is it integrated into our QAPI program? As you know, the State Operations Manual 221-2020, they came out with the new rules and they put a lot in there about infection control and a lot about antibiotic stewardship. So we do want to make sure that it is integrated in there, that we've set clear expectations, that we have some form of a formal report on an annual basis. And what does that look like? And then we have something added to our champions job description, and that we are supporting training and ongoing education, as well as looking at, okay, how do we participate in local, state, or national collaboratives? what do we participate in? So here's where we're going to jump in. And, what's our first question? Well, I'd be curious to know, from everybody, how much time do you think in a month is your work time, productivity time, spent on your antibiotic stewardship program? If anybody can kind of guesstimate how much time are they involved in this? And then what outcomes are you monitoring, that are setting some of those standards and expectations? This is where you guys get to chime in.
This is Jessica at Monroe County Hospital. I think we spend about 8 to 10 hours a week just on antibiotic stewardship.
Wow. Okay.
And we are actually changing what we are monitoring at this time. So we have been through a couple of different goals, and they all started out really good, and then due to just physician pushback, they've sort of changed. But currently we're looking at the amount of rocephin that we use that's initiated in the emergency room and then stopped at discharge or admission, into our facility. A lot of our patients get a dose of rocephin in the ER and then they get admitted, and the admission doctor automatically DCs it because they don't feel like they need it. So they're getting an extra dose of antibiotic a lot of times. That isn't continued in our program. But we have looked at changing Zithromax from IV to PO, and we have looked at something else in the past that I cannot remember at the moment.
That's okay. I see another 4 to 10 hours per week on stewardship, depending on patient load. Has your trend gone down as COVID has essentially gone down? Has anybody noticed a difference, or you're still busy? And check out the chat box, guys. We've got monitoring days of therapy and antibiotics deemed inappropriate. Nice. Inpatient days of antibiotic therapy and patient admissions. % of patients where the antibiogram is documented as being used for appropriate therapy. This is good. I'm trying to switch to PO faster and getting baseline of days. Anybody else have any baseline of days of use to get to PO faster? Has anybody started any of that trending? Okay. So your stewardship team. Now, this is not all encompassing that you must have all of these people on it, but more than likely, as I was looking at this from the CDC, and I'm thinking, yeah, more than likely, this is probably a lot of the people that, sit on your stewardship team, and they probably make up a lot of your P&T committee or your quality committee, infection control. So it just gives you an idea of who you should incorporate into that. The one area that they said nursing non-managerial, I thought that was really good. And we'll get to that later in the education piece as to why I thought, having that one bedside nurse person on would be good. And listening to your ER versus going to inpatient and those changes, that would be, something to have as a potential, one ER nurse and one med-surg nurse, just as a thought. And again, it's just a thought. So these are some of the questions that came out of the new guidance that was put out in 2019 and released in 2020 when you do that gap analysis and assessment. I'm curious, has anybody used the assessment tool from CDC to really kind of hone in and look at your program? And you'll see in this, the first 4 bolded questions are those that in the assessment tool, they were made priority as compared to the other. So it just gives you a look at, okay, what did they change and, how does it really affect me? So again, when you start looking at, your program, can you answer yes, no, partial, I'm partially there, I'm almost there. Maybe I was there and now I've slipped backwards. Again, there's multiple ways to look at this. And then we go to accountability. All right, so in accountability, it was interesting. The 2019 update highlights the effectiveness of physician and pharmacy co-led leadership. They had reported that 59% of the hospitals responding to the 2019 NHSN annual hospital survey had a co-led team. So I thought that was really interesting. And I'm kind of curious, again, who leads your team? When we think of accountability, we must appoint a designated leader / co-leader. Now, this does not have to be, documented in the minutes, like we appoint infection control and quality. It should be in your board minutes as to who is going to be that leader. But I do suggest that just because I think it gives more teeth to it and that board recognition of who's leading this charge. You must have a provider designee to serve as a contact and strengthen the program. Here's where I think, a lot of times the hospitalist works really well in that. Because they're a little bit more readily available. They do suggest that the person who is leading your program has some form of leadership role. And the reason you want that is because they have those skills in communication to engage staff and providers, as well as the ability to, both lead and delegate. And then, performing stewardship rounds. This is not just a one-person job. I stress that on so many things that we do. And then provide training for the leaders. How do you provide those training programs? And we're going to come back to that here in just a minute. So again, on our accountability, we want to think about, who is leading our program? And again, jump in here. Who actually is leading your program? And, who's performing the rounding currently? Who does all of those rounds? Are you solely reliant on the pharmacist to do that or the infection control lead? Just kind of curious as to what you guys are doing. What's working and what's not working. Hospitalist, pharmacy, and nursing do rounds. Thanks, Ruth. Do they round together or individualized?
They round together usually.
Yeah.
Then our stewardship team is made up of the hospitalist, nursing manager for med-surg, pharmacy, quality, administration.
Okay. Thank you. We've got one rely on the pharmacist now. Lots of help from infection control. Yes. Anybody else? Is anybody not doing rounds? And let's talk about what you do on rounds. So maybe you don't want to pipe in here and you don't really know what's happening on your rounds. Does anybody want to talk about how they round and what questions they ask? Is it routine questions or is it something specific that you use as a form? Any of my pharmacists on? Anybody got anything that they use?
We have a form at Monroe County Hospital, but it's not for rounding. It's sort of really like a chart review after the patient, like we get their cultures back and then we look at like, are their cultures positive? Are they on the right antibiotics? That kind of stuff. It's not a rounding thing. It's sort of like a
Internal
checklist.
audit kind of. Anybody else? Is there anyone out there that's utilizing a nurse practitioner as your hospitalist to be part of your team?
We have a nurse practitioner that works with the physician. And, they do it as a team approach.
Okay, good. All right, our next one. So this one is pharmacy expertise. Now, in 2019, they changed this. It used to be drug expertise. That's why I have drug there as well. But CDC really wanted to place an emphasis on the importance of pharmacy engagement for leading the implementation efforts to improve the antibiotic use and utilization in the hospitals. It's really starting to focus on the high value of infectious diseases, what we're using, the antibiogram, and then the drugs that are, utilized. Just like earlier, Rocephin started in the ER, but then they're not kept on it. What does that look like, and utilizing the pharmacist expertise in this. One area is that we do want to stress is the assistance in policy and procedure development. And I do see where that lead pharmacist would take, a stronger play in that, as we look at our program and establish some of those pharmacy-driven interventions, based on best practices or what's evidence-based practices, in the marketplace. So with that, our assessment questions, there was only a couple in there on that tool. But here's one question, and I think it's because, where do we get our education at? So where does your pharmacist receive their education? For ongoing education, workshops, training, online, what platforms, if you guys know, are they getting their education? Guys have any peer networks that you get information from? State initiatives from the public health departments or your local public health department? SIDP program, it was wonderful. Good to know. Did you do that online? Yep, okay. Anybody else? I know I received a lot of information from our local state here in Illinois back in 2019, might have been 2018 even, when this was getting changed, and there was a lot of poster board presentations that presented at the meeting, and it was a full antibiotic workshop that we could go to. And I have a lot of that information still, in some of the poster board presentations that were, displayed. If anybody wants any of that information, I didn't know how valuable it would be, but if you're looking for ideas, I do have some of that. So, feel free to give me a shout. Pharmacist works for Cardinal Corporation. Oh yeah. So ISMP does put out a lot of information. Anybody else out there contract their pharmacist? get information elsewhere that they get from their service line. All right. Next one, action. So action is, implement interventions such as prospective audit and feedback pre-auth to improve the antibiotic use. This is another one. In 2019, they made some specific areas a priority, and then they took us down another path a little bit, and you're going to see a couple of slides on this. So when we think about those priority areas, these are truly considered the foundation of your program, and the prospective audit and feedback, the pre-authorization and facility-specific treatment guidelines, and looking at what are you guys having to implement in that area. When we think about the action focused on, some of those common indications, and some of those most common, again, community-acquired pneumonia, urinary tract infections, skin and soft tissue infections. So these all stayed in that priority area. And then they said, okay, these are going to be the other infection-based interventions. And it was your sepsis, your MRSAs, C. diff, culture-proven invasive infections, so your bloodstream infections. So this, I will tell you, review of planned outpatient parenteral antibiotic therapy. That was a new term for me, OPAT. I know it is listed in, the guidance from the CDC, but that one was one that I was very unfamiliar with. So if anybody has any input on that one, I would love to hear it because that one's new. Nobody else had anything either, huh? Another area in action that they changed is they have provider-based interventions, and then we'll also have some pharmacy-led interventions and a few others. So again, looking at, okay, what is the provider doing? And this is, providing some of those antibiotic timeouts. And this is where I didn't have the question listed, but I would like to know, when you guys are working with your providers and you're doing your rounds, do you do a specific antibiotic timeout? And how does that look? What do you ask? When do you decide on that? How do you decide when to have that? Is it when the cultures come back, or is it within 24 to 72 hours of therapy time? What do you guys do? Only as part of discharge planning. Okay. So, and you'll see there, the CDC put out 4 key questions that you should be looking at when you do timeouts. But again, just kind of curious as to what others are doing. If you've kind of implemented this in part of your rounds, or, it's kind of new, not done very often. Nope, we don't really do it. We depend on the doctor to decide when, or if the pharmacist comes along and does a review and says, suggest going to PO. How do you decide?
In general, I don't know if this is what you're looking for, but our pharmacist huddles with the hospitalist, and she keeps track of the cultures when they come back to make sure that the antibiotic's appropriate, and then also looks at the various lab tests and the levels to make sure that they're appropriate for that particular patient.
Good. And that takes us to the next one, pharmacy-led interventions. What is the pharmacist doing as compared to the physician doing? And again, documentation of indications for antibiotics. Do you have automatic changes from IV to oral therapy, or dose adjustments that the pharmacy can do? you know, looking at optimization of whatever antibiotic you're utilizing. Any time sensitive automatic stop orders, so the nurses know to ask. And I know the pharmacists are doing drug to drug interaction reviews already, but what else is happening? Anybody have anything there? Does the pharmacist do the dose adjustments if we're looking at any kind of organ dysfunction, or it's building up too much in their liver or kidneys? Or is that more of a reliance on the provider? Provider consults the pharmacist. Thank you. Good. So again, we're still in action, and the CDC did put out that microbiology should have some interventions. So again, you know, thinking about, okay, what's coming from micro, you know, what are we getting, you know, and obviously our testing results. So how do you guys use microbiology in your antibiotic stewardship program? Pharmacist does dose adjustments and monitors days of therapy for how long antibiotics should be given. Antibiogram issued to clinics annually. Nice. When you guys put out your antibiograms, do you put it on a slick card that the providers can carry in their pockets? Do you keep it at the nurse's station for them to look at? Where do you keep those posted? I know back in the day, we used to give them a card at med staff. And again, it was back in the day, they had mailboxes, and we'd throw one in every mailbox as well. Laminated copies for each clinic. Nice. Share on hospital SharePoint page. Good. In a notebook at all nurses stations. Nice. I do have to ask this because I'm just curious. Again, curiosity. Do you feel like the physicians are looking at it? Or are they just kind of waiting for someone to feed them some information as well? And they just pick up the call. Depends on the physician. Yeah.
I think the physicians do look at it because they had a discussion when we handed it out about the changes from year to year.
And when you guys do that and you put out the changes, who does the education on that? Does it come from microbiology, infection control, pharmacy?
Usually from the lab.
Lab, okay. So it's still under action. So we have nursing-based interventions. How are your nurses empowered for prompting timeouts or looking at, are there any, you know, safeguards put in place as far as reminding them to ask for a timeout that they've been on it long enough? Any triggers in your EMR system to move from that IV to oral transition? Anybody have anything? Present at med staff meeting annually. Thank you, Ryan. Anybody, how do you guys present this to nursing? You know, as far as, you know, providing them updates and education. Nursing is part of discussion at Huddle. Good. You know, looking at, I know in Illinois, we had a big focus on blood culture contamination. So ways to reduce those contamination and indication when to obtain cultures, especially if we're looking at urine cultures, you know, and they're in our standard protocols versus having to call. Looking at when a patient is able to tolerate oral medications to switch to oral versus IV, or is it a prompt of so many days IV, you know, in your protocols? And more than likely you wait until, you know, lab results come back first before you make that decision. We've had some input, thank you. All right, moving on, tracking. And sorry, guys, I did not put the survey assessments, the self-assessment in there of all of the action. There was quite a few in there, so I didn't plug them in because it didn't look pretty on the slide. But if you guys want that report, I can show it to you and get it over to you if you haven't used it. So we get into tracking. Not a whole lot came out of 2019 changes. The one thing that they were really pushing was the NHSN AU option. And I, you know, I'll be honest, I'm not sure our critical access hospitals and small rural hospitals are utilizing that. So, but really looking at monitoring antibiotic prescriptions, you know, what are we prescribing, policy and guidelines, you know, have interventions improved antibiotic use and patient outcomes? You know, when we start thinking about, okay, what are we really doing, you know, as we look at this? You know, if we are a program, you know, is getting assessed and we're evaluating it, and we're starting to look at our policies, our procedures, you know, are our processes and interventions really meeting the outcomes that we expect to see? You know, and that's where tracking comes into play. And again, it's those outcome measures, you know, for quality improvement. And does it make sense? This, again, you know, because I will tell you, this is my weakest knowledge point. Standardized antimicrobial administration ratio, the SAR risk adjusted benchmark. Never used it. Yeah, as a bedside nurse back in the day, and even, you know, in some of my routine clinical stuff, I've not seen that, you know, for us as nurses. Now, pharmacists and physicians, yes, I'm sure you guys are very familiar with this. I'm just not. Yes, the slides were put in the chat box early on. Somebody's asking about the slides. But yes, you will get these as well. And if you want any of the resources, I can plug those in as well and put them in for everybody. You know, how I built these slides is right out of the CDC manual. So if you guys want that, I can gladly send that over as well. When we're looking at outcome measures, what are some of those outcome measures, you know, when we start looking at C. diff infections, antibiotic resistance, you know, what are we starting to see, you know, and looking at, okay, how do we improve this? So we have, you know, our self-assessment, the top four, you know, bolded, those were made essentially priority as we move forward, you know, from the 2019 recommendations that were put out, you know, looking at the stewardship program, tracking through the NHSN, antimicrobial use option. So is anybody doing that? You know, again, just curious if anybody is doing that. And my gut says no. So when we think of, you know, our tracking, are we tracking in this one, if we have any CFOs on or those numbers people, you know, the financial impact, Are we achieving any significant cost savings, or particularly drug cost savings? And what does that look like? Granted, they're not supposed to be our primary outcome measure, but if we can demonstrate savings through our antibiotic stewardship programs, that's a win-win. Looking at, are we monitoring the antibiotic costs? Are we assessing that pace at which our costs are rising, before the start of the stewardship program? Are they going up? Are they accessible? Are we having to look at other medications that are a higher cost because certain ones are not available currently? So again, looking at what can we, really focus on, and then we have, process measures, thinking about what are we doing for quality improvement? And as we kind of dig into this a little bit, any specific treatment recommendations that we're doing, assessing how often are patients prescribed unnecessary or duplicate therapy, and how did that happen? Can we identify a root cause or an opportunity for improvement? Are they discharged on the correct antibiotics? Now granted, it's a lot of work to track that from discharge then to their follow-up with their primary, did we give them the right antibiotic or did they have to switch? So I don't know that, we want to go to that detail, but again, I'm just kind of curious if anybody is doing any of that. Are you tracking certain prescriptions or by provider? Certain providers are prescribing certain medications, or do you keep it very, yes. Oh, good. And then we go into reporting. So, and reporting didn't have a lot of changes. This is typically just like it says it is, it's reporting. Here's where we're at. This is what we're seeing. This is what we're doing. Looking at, what kind of education and things we should be putting out there, which we'll talk about in a minute. But looking at medication use evaluations, and I've not seen a lot on that as far as, how that's being utilized the best. But looking at, how are we providing facility specific information to motivate or improve prescribing? What are we putting out there to our providers? Is it through med staff? Is it through P&T? And looking at what needs to change. Are we working with our local or state health departments and infection control, or, those resistant meds, those threats, some of those things that are coming out, especially when COVID hit, we started seeing that impact. What kinds of reporting is happening and how are we staying current on it? And then, as I'm talking, I'm thinking there's so much, and some people are spending maybe 4 hours a week on this. And I'm thinking, and it can take up, so much time, so definitely looking at delegation and how you stay in communication with folks, is essential in staying on top of all of this. Under reporting, there wasn't a lot when we look at this, again, do we share our individual provider specific reports, or do we give our providers their own? P&T staff provides info to med staff on drug costs and effectiveness. Nice, good, thank you. Looking at, adherence, that second question. Does your program report adherence to the treatment recommendations to the prescribers? And how does that look? And we've already talked about the antibiotic. Anything else? All right, next one, education. So now this is the last of our 7 that we have. So this is the area that, I think I have seen some amazing poster board presentations and flyers put in ERs, of how are we educating our community? This is why you're not getting an antibiotic when you come to our facility. And this is when you would get an antibiotic, but also educating when we're reporting. You know, we often get so hung up on reporting certain measures, you know, because we have to, but also how are we educating, you know, even some of our other staff, you know, so that they understand why we're doing this. You know, it's not just because I want to, you know, track something, it's because here's what it gives us in the end. And then looking at those formal and informal education settings, you know, are we providing nursing updates and education? Is it through the LMS system? Is it through nurses meetings? Is it just through a training thing that they can take? Are we putting information out there on our screensavers, you know, or posters, newsletters, department information? You know, how are we doing that? And then one of the things they did mention in the 2019 updates are case-based education. So in my mind, I thought of this as like the grand rounds. And one of the things that I used to absolutely love was you could have physician grand rounds, but also nursing grand rounds. And nursing grand rounds could include, you know, a pharmacy-led grand round and a physician-led grand round, a lab grand round. You know, that the nurses got some additional training and it was case-based. You know, so we could actually follow the case, understand it, and what could we have done differently? What could have triggered earlier that we might have identified to change this prescription or, you know, dosing or something. And then again, looking at our local, state, and national training sessions, you know, where are you getting your training and, you know, how is it coming back? But then, you know, it's great to send someone off for training, but you also want them to bring it back and teach others, you know, and how does that happen? You know, what are the requirements? So if I'm an infection control nurse and I go through the EPIC course and, you know, I've learned everything I've passed and been successful, how am I bringing that back to the facility so the rest of the facility benefits from that same training? You know, and those are some things that, you know, just to think about in your team. So our education assessment questions, this is, you know, that nothing really had changed. You know, when you look at that self-assessment, do you provide education to prescribers and other relevant staff, you know, on optimal prescribing, you know, but also looking at some of those disease specific things, you know, and what's growing in a urine culture and how did it change? What happened? How did it get into the kidneys? You know, what did we do differently? You know, review that entire case if it went south, you know, especially our sepsis patients, you know, and just kind of break it down and do them as case studies. And then, you know, doing that prospective audit feedback process. I read somewhere they call that the handshake stewardship. And I don't remember where I read that, but I liked it. So, and it's really looking at, okay, here's what we did for your charts, your patients, and here's our feedback from this, you know, and they take it and they can do whatever they choose to with that information. All right, this is the last slide, you guys. So here's where I need, you know, input. What's your greatest challenge with the antibiotic stewardship program? And then what is your greatest success or implementation achieved from it so far? You know, when we're looking at those outcome measures, what have we seen that has been that, wow, you know, this is what we've done. You know, have you changed up some of the education you give to patients? Put anything on your website on education about antibiotics? Greatest challenge is patient demands for what they don't need. Oh, I hear you. Yes. You know, and anybody got any really good education that they've put out there that you'd be willing to share? You know, take pride in what you've developed, you know, and share it. And I'm all about stealing. So anybody else? You guys are a quiet bunch. Was this helpful? you know, when we started reviewing it and looking at this. Greatest success is order sets based on best practice. Nice. Challenge is getting patients to understand antibiotics are not always indicated. And I fully agree. So, you know, everybody thinks they can just go in and get an antibiotic and it's going to cure something. And it doesn't always work that way. You know, and I think of, you know, and this is me as a mom back in the day, you know, and I swear my kid has strep and they just need an antibiotic and it's viral and they come back negative and they don't need anything. Just got to let it run its course, you know, and, but man, parents can get demanding. So, anybody else have anything? What has been the greatest challenge of implementing your program? Maybe not just managing it, but truly implementing it. All right. That is all I had. I'm going to come back on video now. So, hey, so anyways, what else can we do? I know next week we're going to talk about PCMH. That's something that's very near and dear to me. I love PCMH because I think it's the way we should always practice. But, you know, if you guys want another session or another topic, what topics would you like to see? Thank you for that fantastic presentation. Helped a lot with access and thinking about our program, things we do and things we can do to move forward. Thank you very much for that. So,
Yeah.
So, but again, what are some other topics you guys want to talk about? I was on a 2-day, I guess they call them watch parties with a fellow Brian Lee with Custom Learning the last 2 days. If anybody was on that, they had some great speakers. But some things that we got on there was critical thinking skills, you know, talking about Gemba boards and, you know, doing rounding with our Gemba boards. You know, those were some really good things, you know, that I thought we could bring some of that, you know, to you guys. You just got to kind of give us an idea of what works, what doesn't work, what would you like to hear? You know, so that we can help you. We're here to provide the education. So it's a matter of looking at how we can change things. You know, I'm dependent on all of you for ideas. For those of you listening to the recording, I'm dependent on you as well. You know, please send us ideas. Tell us what you want. Do you want something in finance? Do you want something, you know, in a completely different line? Do you want to see, you know, something totally different, population health? Or, you know, I know a couple of years ago, the big one was chronic care management. You know, what else can we help you guys with? How to give and take orders. Oh, as far as from a physician or as a leader to staff. Okay, Kim, I'm writing these down. So anybody else, you know, this is great. You know, and you guys can throw out any ideas, that nothing's wrong. You know, there's no bad idea. And if you're thinking it, guarantee somebody else is thinking it. Marketing annual wellness visits. Oh, that's a good one. That one's fun. You know, that one's hard, but yes. You know, another one I know I'm doing coming up is on swing bed and swing bed management and looking at outcome measures for them. Health literacy assessment of patients from a more technical angle. 2-minute rule and OBS versus acute. Oh, that's a really good one, especially for our case managers. That would be a really good topic. So this is great, you guys. Keep them coming, because these are the things that we need to know. What should we be looking at? As you guys know, I work with 2 different universities as well. I will gladly research with a lot of our doctoral students, you know, what are they doing, you know, and they can do some research as well and help us. Anything else? I think we're ready for that last.
Wonderful. Okay, yeah. We
Sure.
will do our post polling now. So you'll take a couple of seconds. It shouldn't take long. We have three questions now that pop up. And yeah, so we'd like to know how this presentation helps you to identify antibiotic stewardship activities that are best for your organization, and also your understanding of how to establish a gap tool for antibiotic stewardship activities that are currently underway. And then we want to know how you will apply this knowledge gained to this educational training to encourage quality improvement within your organization. So, yeah.
One of the things, I know they put the health literacy assessment of patients. Do you also want to look at the social determinants of health? Is that an area that people are wanting more information, not? How do we assess that? Another one is your community health needs assessment. How do you utilize that? They go hand in hand. Yes, I agree. They do go hand in hand.
Yeah. Wonderful information today, Angie. You did it again. You provided great information, and we do appreciate that. And we appreciate.
Yeah, they lie. So thank you, guys. So
no, not true at all. They speak truth only. Yeah, and we just appreciate everyone attending and just everyone in the willingness just to share from your perspective and from your organization. It always just adds so much to the conversation, and we just greatly appreciate that. And Angie, we always appreciate you and your expertise. And yeah, like you said, next week we have a patient-centered medical presentation, and that will conclude this quality series. But of course, that doesn't mean we're always looking for more ideas and how to build out our webinar series. So yeah, we'll be looking forward to that. And looks like we have, somewhat confident. Yeah, looks like we're doing good across the board there. Thank you all for completing that.
Yes, thank you, everybody. Again, greatly appreciated. Thank you for your feedback and participation, and we will see you next time.
All righty.